Professor Ravi Chaoui, who works at the Center of Prenatal Diagnosis and Human Genetics in Berlin and at the Charity University Hospital, Hamburg University, Berlin. Prof. Chaoui is an eminent educator. He was an ISOC board member from 2003 to 2013, including 2 terms as a chair of the Education Committee. He was the Stuart Campbell Award for Education awardee in 2018 and the chairman of the ESOP World Congress in 2019. And he's an ESOP fellow since 2013. Actually, Ravi doesn't need any introduction. He gives so much of so many educations in the World Congress and wrote 3 books, and all of us had read. So it's my great honor to introduce Ravi to this plenary on Fetal Echo for All. Ravi, please.
Good morning, my dear colleagues. I'm grateful for the kind invitation to give today a talk on the fetal heart and how to examine the heart and to diagnose common cardiac anomalies, in other words, fetal echo for all. If you look at now the reason why to screen, you know like me that congenital heart anomalies are the leading cause of birth defect associated death. The morbidity and mortality is improved if cardiac anomalies is known early in life, ideally diagnosed prenatally. The $1 million question is, what is the safest trip for the baby from the womb to ICU? Is it the walking mom, A? Is it B, the quickest ambulance, the Ferrari? And it's real, there is a Ferrari as an ambulance. Or C, is it a helicopter? Yes, you guessed correctly, the walking mom is the correct answer. How common are cardiac anomalies? The cardiac anomalies actually are fixed. They have around 10 out of 1,000 births, but out of the 10, there are 3 which are complex, and these are the most important one. In other words, you will have a risk of 1 out of 300 cases having a complex cardiac anomaly, and in utero is the incidence even higher. Now, looking to the number 1 to 300, it reminds me always the Down syndrome frequency in a woman aged 35 years and more. So in other words, in younger patients, the risk of having a complex cardiac anomaly is by far higher than the risk of having child with Down syndrome. And imagine for a second how much money have been spent all over the years for screening for Down syndrome, from the amniocentesis in the 80s to the soft marker in the 90s, triple test, nuclear translucency, and in the recent years also NIPT. And I hope now that time has gone that we can concentrate on screening the fetal heart. All started with Laurent Fermont and Lindsay Allen, who, as cardiologists, said the simple way is to teach obstetricians to perform ultrasound of the fetal heart or radiologist, and they said ideally you don't need to look for let's say a specific scan. Use simply the 2nd trimester screening and examine the fetal heart. There are of course indications for fetal echo which are the high risk group for congenital heart anomalies. They are directly referred to a specialized center, but on the other hand, you know like me that the main group are the one detected on screening, and this is why, because the cardiac anomalies do not have let's say a priori risk to occur. This is why today I will discuss with you how to improve the fetal cardiac scan, and in my opinion there are 3 major points. One group is the how to master the technique of your ultrasound machine, and the second is to master the normal anatomy. And once you know let's say every region of the heart very well and analyze it very well, then I'm sure you will know that you should know the typical cardiac anomalies. Technical aspects are crucial, but I will not have time to discuss with you all these, like how to use the transducer, how to adjust the presets, optimize 2D and color Doppler, and getting, let's say, the good planes on screening and taking your time. But if you want to read more, I would recommend you the book I wrote with Dr. Abu Hamad on the fetal echocardiography. This is the 4th edition, and we wrote several chapters like cooking recipes from the scanning room. Now, as you know, we have the ISWO guidelines of the heart, and there are now an update appearing soon. I hope, in the next month. But what I want to emphasize here that your standard should be always higher than the protocol and guidelines. So if This is why I try to learn to examine the heart from the upper abdomen toward the great vessels, including the 3-vessel trachea view. And the first step is, as you see here, a sweep from the upper abdomen toward the 4-chamber view, demonstrating that the stomach is on the left, the heart is on the left, and the descending aorta is also on the left. The next step is you analyze the thoracic situs with the heart position and axis. Drawing a fictive line will divide the thorax into 2 parts. 1/3 will be on the right side and 2/3 on the left. The cardiac axis pointing to 45 degrees to the left side. The next step will be to analyze the valves and the ventricles. The left ventricle forms the apex of the heart and is longer than the right ventricle. And looking carefully to the tricuspid attaches lower on the septum than the mitral valve. And in this plane, you will analyze the intact of the interventricular septum, and looking to the interatrial septum, you see the gap of the foramen ovale with the valve of the septum secundum bulging in the left side. Looking carefully to the region of the left atrium, you see that the border of the left atrium is irregular due to the pulmonary veins, and the area behind the heart is quite small, including mainly the descending aorta. Important, in my opinion, is that you should focus on getting an excellent image, because it has been shown that a very good image quality is the prerequisite of having a precise diagnosis, also in ruling out complex anomalies. So I will ask you to focus on getting a very nice image in order to have a good normal anatomy and excluding cardiac anomalies. And one of the crucial planes are, of course, as I told before, the 3-vessel and trachea view, where you can demonstrate the pulmonary artery, the aorta, how they merge together to the descending aorta. In my opinion, and many opinions of others, is color Doppler in the meantime considered as a main tool, and not only to be used when there is a cardiac anomaly. And in this plane, in this view, you can demonstrate the typical images of the 4-chamber view, 5-chamber view, the short axis, and the 3-vessel trachea view. Not only if you have a cardiac problem, but also on a routine scan, you may need color Doppler, especially if you have bad scanning conditions. Color Doppler helps you. So if you look at now this image of the 4-chamber view, you don't see anything. And this is why I say that color Doppler is your safety airbag, because if I show you the dual picture, you will see on the right side that this heart appears to have a normal 4-chamber view with a normal filling of both ventricles, ruling out a single ventricle hypoplastic left heart, right heart, or large AV septal defect. So on the 2D, you will not be able to see anything. This is why use the color not only when you have a cardiac problem suspected, but also on the routine routine scan. You will be surprised how good you will be having good images. Now, what is expected from the people doing scan? It depends what you are doing. In general, at the level of screening, I want you at the end to report the normal being normal. And once there is some abnormality, I want only to know in the first step that there is something abnormal. And later on, when you have more experience performing fetal echo, then you will have to make a precise diagnosis. This is why now we move to the second part of the talk, focusing number 3 on how are the anomalies described. The anomalies of the 4-chamber view could be some of these typical ones, like a dextrocardia or a huge heart or a small left or right ventricle, or you have a single ventricle. You may have septal defect or arrhythmia. So let's start with the simple signs of when you perform let's say the routine examination to demonstrate that the cardiac axis and the heart are on the right side, because this is the typical picture of a cardiac abnormality, especially when the heart is rotated to the right side. And this can easily be done if you think of starting from the upper abdomen, and you see here the stomach is on the left while the heart is pointing to the right. So actually, in my experience, to diagnose dextrocardia is quite challenging task, but I think when the heart and the stomach are on different sides, it can be easy if you do it systematically. There are a second group of obvious findings. What are the obvious findings? Like, for example, this one here, when you have large tumors, I think this is something obvious that everyone can discover. Or when you have a huge cardiomegaly, like in this fetus with a critical aortic stenosis, when you see a huge dilated left ventricle with the echogenic wall as an expression of an endocardial fibroelastosis and critical aortic stenosis. Or the typical third diagnosis is an Epstein's anomaly, where the heart is so enlarged that it reaches from rib to rib fills the thoracic cavity, compressing the lung, and looking to color Doppler shows the severe regurgitation, explaining why the dilation of the heart is so huge. The next group of the fourth-chamber view anomalies are the septal defect. The septal defect can include, let's say, ventricular septal defect, the different muscular VSTs or inlet VSTs and outlet. But I think the most common one are the muscular one and the perimembranous one. If you look at now for this large septal defect, this was a fetus with trisomy 18. You see the polyhydramnio, you see the echogenic focus, but you see that the large VST is found in this plane. Most common anomalies seen in the fourth chamber view with color Doppler are very tiny and small muscular VSTs detected on color Doppler. So these are in general accidental findings, and they have not, let's say, big impact, but we'll discover them when you are using routinely color Doppler. I think the most important abnormality in the fourth chamber view from the point of view of septal defect are the atrioventricular septal defect, a combination of atrial septal defect, ventricular septal defect, and an abnormality of the AV valves being a common AV valve. What you see here is in diastole the more or less larger gap. Sometimes it's small, but a regular finding in the fourth chamber view is the linear insertion of both valves, because this is a common valve and you see it as a single line. Look at here now the two arrows showing you that the AV valve is in one plane. So look at now here this video showing you a large atrioventricular septal defect where in systole the valve are in one plane because this is a common valve. In color Doppler is the typical picture of a mixture of blood across this common valve showing the atrial and ventricular septal defect at the same time. A large group of diseases, around 10% of all cardiac anomalies are the small left ventricle, including on one hand the hypoplastic left heart syndrome, on the other the aortic coarctation. Both appear with a small left ventricle. But the main difference in both is that, and focus on this side, that in the hypoplastic left heart syndrome, the left ventricle is absent, almost absent or small, and there is no function. On the other hand, in an aortic coarctation, it's mainly narrow and has a good function. So let's see now some examples. So what you see here is the hypoplastic left heart syndrome. The heart the heart apex is not formed anymore by the left ventricle but by the right ventricle. If you look at now carefully to the contractility, there is zero contractility on the left side. The wall is echogenic and there is in color Doppler no filling. If you look in comparison to aortic coarctation, what you see here is a ventricular disproportion with a narrow left ventricle. The apex is still formed by the left ventricle, and especially, and this is what I like most, in color Doppler you see clearly the filling of the ventricle. I think I prefer to use the filling of the left ventricle, the normal filling, better than to focus on the apex of the heart formed by the left ventricle. Now you see in comparison these two hearts. On the left side, the hypoplastic left heart syndrome with an almost no filling of the left ventricle, whereas in the aortic coarctation you have a filling of the left ventricle. And to confirm the diagnosis, you will refer to the three vessel and trachea view, and you see here the typical three features. On the left hand side is the normal finding with the aorta and pulmonary artery as a normal 3VT, and in the middle is hypoplastic left heart syndrome with the reversal flow, and on the right side is coarctation with an antegrade flow in the narrow aortic arc. And if I remove now the schemes here, and you will see the images on color Doppler showing you the normal anatomy on the left, hypoplastic left heart syndrome with the reversal flow in the middle, and the antegrade flow in the narrow aortic arc on the right. I will not discuss with you long on the small right ventricle, but the common two ones are the tricuspid atresia with the VST and the pulmonary atresia with intact septum, so leading to the kind of hypoplastic right heart syndrome. One condition which should be emphasized is when we see a one ventricle or single ventricle. The typical picture of a single ventricle is what is called a double inlet ventricle, means that there are two atria with two AV valves draining into a common chamber, and you see here on this video how it looks like. So at first sight it's surprising because you think there is only one valve, but with color Doppler you see the two valves, and there is a remnant chamber on the right side because this is a double inlet left ventricle, and you see the small right ventricle where one of the great vessels is arising, in general the pulmonary artery. Now let's move to the great vessels, and here in these planes, I think there are three important planes we'll be getting. The left ventricular outflow tract as a kind of 5-chamber view, demonstrating the aorta arising from the left ventricle with the continuity between the septum and the ascending aorta, and the 3-vessel view with the bifurcation of the pulmonary artery, and the 3-vessel trachea view with the typical V sign pointing to the left, ideal in color Doppler. With these 2 to 3 planes, I think you will be discovering the main hints for the great vessels. I'm sorry, there is a mistake here. It should be in the great vessels. So VST and the overriding aorta, parallel vessel, discrepant vessel size, discontinuity of vessel, or the aorta to the right side as right aortic arc, or abnormal number of the vessels. I will not be able to cover all of these. I will focus on very few. And as you see here, the typical hint of the 5-chamber view is when you see here this overriding of the aorta with the VST, in general leading to a dilation of the ascending aorta, because blood draining from both chamber lead to a dilation of the aorta. So the typical first anomaly you think of is, of course, tetralogy of Fallot, described by Etienne Fallot, 1880. The typical signs of tetralogy of Fallot are 4, and these are the VST, the overriding of the aorta, the pulmonary stenosis, and hypertrophy of the right ventricle. But the hypertrophy is a result or a consequence of long-term let's say, disease after birth, and this is why today, prenatal and early postnatal, we have 3 signs. This is why we should call it rather today the trilogy of Fallot, including the VST, overriding aorta, and the pulmonary stenosis. So in the 5-chamber view, what we'll be discovering here on color Doppler is the typical picture of an overriding of the aorta, reminding like a letter Y. And but this is the first hint. The diagnosis is then made in the second plane, where we look at to the 3-vessel trachea view, or the 3-vessel view, demonstrating the narrow pulmonary artery in comparison to the aorta. Remember, the normal V sign, they are of almost equal size, but here in this case, you see the narrow pulmonary artery with an antegrade flow. Now, this is here again a summary that it is only a hint, because once you look to the next plane, you will discover the origin, the size, and the flow across the pulmonary artery. And then if you see a narrow with antegrade flow, it is tetralogy of Fallot. If you see a normal pulmonary artery, it can be simply an overriding of the aorta called malalignment, VST. One more severe disease is a very small pulmonary artery with a reversal flow as pulmonary atresia with VST. Large pulmonary arteries can be seen in the absent pulmonary valve syndrome. And if you find out that the pulmonary artery is arising from this overriding vessel, then it can be a common arterial trunk where the origin of the pulmonary artery is the common trunk with some turbulences and dysplastic valve. Let's move now to one interesting disease, which is the transposition of the great artery. This is a disease where there is a wrong origin of the aorta from the right ventricle and wrong origin of the pulmonary artery from the left ventricle, and you have a parallel course of the great vessels. You see the diagnosis cannot be achieved in the 4-chamber view, but only by demonstrating let's say, the parallel vessels on one hand, but also could be also even simpler to diagnose that in the 5-chamber view, the pulmonary artery is arising from the left ventricle. So once you perform the LVOT, you should demonstrate under normal conditions that there is no bifurcation of these vessels. Otherwise, as you see here, it is a typical picture of a pulmonary artery arising from the wrong ventricle, from the left ventricle. So if in the 5-chamber view you see a bifurcation of the aorta, it's not the aorta, it's very likely to be the pulmonary artery arising from the left ventricle. One of the typical features we like to teach is in 9 out of 10 cases, the single vessel in the upper thorax. It was described as a sad aortic sign, as boomerang sign, as eye sign, and so on. So what is important to keep in mind is that it is the kind of discrepancy between a normal 4-chamber view on one hand and a surprising 1 vessel in the 3-vessel trachea view. So again, look at now this picture here. What you see here is a single vessel. How comes that there is a 1 vessel? Because the pulmonary artery is hiding behind the aorta, and this is here the 4-chamber view appearing normal, and you look at the 5-chamber view, and then you realize there is a bifurcation of the pulmonary artery rising, and then getting to the 3 vessels, you'll see that the aorta is a single vessel in the upper thorax. And what you do then is you turn the probe in order to get almost a sagittal view, and you see that this is an oblique view because of the ribs shown here, and then you can demonstrate the parallel course of the vessels. This is not the plane you will use accidentally on every fetus. It's only you seek for when you know that it could be a transposition or other disease. So, and the angle, as you see, is the plane is from the left hip to the right shoulder. This is where you can get this plane. A similar disease sometimes is the double outlet right ventricle, when you see the both origin of the great vessels are from the right ventricle. I think I gave you a short overview and hope that we could keep in mind how to diagnose perimembranous VSTs, AV septal defect focusing on the linear insertion of the valve, the difference between hypoplastic left heart syndrome and coarctation, the function of the left chamber, the filling in a narrow left ventricle in coarctation versus an almost absent feeling of in hypoplastic left heart syndrome. I showed you the severe regurgitation in Epstein, the double inlet ventricle in single ventricle, and also the typical hint of an overriding aorta, as could be a tetralogy, but many other diseases, and the parallel course in transposition and double outlet right ventricle. In other words, I hope I could show you within this short talk how to improve your fetal cardiac scan. And if you think you are not very good, you should change something in your work, because as Einstein said, insanity is doing the same thing over and over again, but expecting different results. So work on mastering the technique, work on understanding the cardiac anatomy, and know the typical cardiac anomaly. So it needs hard work, but I hope that your work can be hard, that at the end of the day, most of your patients with congenital anomalies will walk into the hospital for delivery, and you will receive Christmas time images like this one with the breast after surgery and the happy baby and happy family. I thank you very much for your kind attention and hope you are stimulated to do a better cardiac scan and learn from my talk. Thank you very much.